Without further ado, it is my absolute pleasure to welcome our first presenter, Professor Joy Ho. Professor Joy Ho is Professor Alan Ung Chair in Haematology at the University of Sydney and Head of Department and Director of Research at the Institute of Haematology at the RPA. She's Head of the Myeloma Unit and Clinical Lead, Haematology CAR-T program in RPA. She is the founding director of the Sydney Blood Cancer Research Institute, and she has brought multiple clinical trials on novel myeloma therapies, including immunotherapy and CAR-T therapies, to the RPA and Australia. Joy was president of the Haematology Society of Australia and New Zealand in 2013 to 2015. She's foundation member and was deputy chair of the Medical and Scientific Advisory Group of the Australian Myeloma Foundation and member of the International Myeloma Working Group. She was elected to the board of the International Myeloma Society in 2019, and she's served on the Education Committee since 2016. She served on the ALLG Scientific and Executive Committees and chaired the Laboratory Science Committee in 2005 to 2011. In 2017, she was appointed to the Pharmaceutical Benefits Advisory Committee by the Australian Government. For the American Society of Haematology, she is an invited member of the International Members Committee since 2016 and was appointed the Vice Chair in 2021 and Chair of Metrics Subcommittee for International Programs in 2018 to 2021. Her awards received include the Albert Bakey Memorial Medal, Kanematsu Memorial Award, Arnott Fellowship in Cancer Research, New York Academy of Sciences Fellowship, and Oxford Nuffield Medical Fellowship. She's the author of multiple publications on myeloma, lymphoma, cellular immunotherapy, and hemoglobinopathies. We are so grateful that she can be with us today, and she's presenting on T-cell directed therapies. Thank you so much, Professor Ho.
Thank you very much, Kath, for that very kind introduction. I first want to thank Myeloma Australia for inviting me to speak at this webinar. I think it's particularly exciting that once again, Myeloma Australia has continued to advocate for all patients and doctors treating myeloma during this National Myeloma Month, not only to raise awareness, but also to provide education. And on that basis, I'm aware that my audience in this webinar is likely to be a little diverse. And so in catering for that, I hope to explain concepts on a perhaps more basic level, especially for our patients, for which I'd ask any colleagues who are experts to bear with me, while in some situations, I will also discuss some results at a more technical level, so that if there are additional questions, please don't hesitate to ask questions after the talk or even offline, as Kath explained to you just now. I've been given the brief of looking at T-cell directed therapies, and the two main categories of T-cell directed therapies I'll talk about are illustrated on this slide. On the left are the CAR T cells, and on the right are bispecific antibody T-cell engagers, or BiTEs. My agenda is set out here. I first want to give you a rundown on some of the crucial data, many of which have only been published in the last year. I hope that by the time I finish this talk and I have looked at both CAR-Ts and the bispecifics, we may ask which is better. But you may see that this may not be an appropriate question, as they could, for instance, be used one after another. Secondly, what implications will these developments have on different patient groups? The patient with relapsed myeloma being the key populations we are treating at this stage, either early or late relapse, but also those who are newly diagnosed, whether they're eligible for transplants or not, and the effect of age and performance status. And in relation to this, how and when do we use these technologies? Do we save them until patients break through other therapies, or is it better to use them as early as possible or at diagnosis? And importantly, what happens when they fail? So what is a CAR-T? CAR stands for chimeric antigen receptor, and the T cells are one part of the immune system, with B cells being the other part. The CAR approach uses lymphocytes, which are immune cells transfected by gene therapy, with chimeric antigen receptor genes. They're called chimeric antigen receptor. Chimeric because it combines the effector functions or the immune action of T lymphocytes in killing tumor cells, shown on the bottom of this diagram, with the ability of antibodies from the B cells, the other part of the immune system, as the receptor to recognize targets on myeloma cells in a very specific manner, as shown on the top of the slide in the green part of the molecule. The tumor antigen binding function of CAR, as I showed you and in the top part of the molecule, is usually accomplished by a single chain variable fragment containing the heavy chain and light chain variable domains joined by a peptide. This is from the B cell antibody. This is then connected through a hinge region and a transmembrane domain to the co-stimulatory domains and the CD3 zeta signaling or activation domains, this being from the T cells, hence chimeric. As you can see from this diagram, there are different designs. For instance, the co-stimulatory domain can be a molecule called either 41BB or CD28 with different properties. And as you can also see from this slide, there are different generations of the design as well, incorporating different number of co-stimulators. In very simple terms, this slide summarizes the procedure. A patient undergoes leukapheresis to collect the T cells by an apheresis machine from the bloodstream. These cells are then delivered to the manufacturing site, which is mainly in the US and also in Europe. The cells are selected and activated, and then the chimeric antigen receptor, or CAR, that I showed you just now, is inserted by gene therapy using a virus such as lentivirus. The cells are expanded and are then ready for sending back to Australia. The patient undergoes a short course of chemotherapy called lymphodepleting chemotherapy, which is, as it were, to make space for the CAR T cells to expand, and the CAR T cells are then infused like a transfusion back into the patient. There are two main CAR Ts that have been approved in the United States and Europe for myeloma, and they have the names given here: idacaptogene or ida-cel on the left, and ciltacabtagene or cilta-cel on the right. They both target the antigen called BCMA, which stands for B-cell maturation antigen, a molecule that is highly expressed in myeloma cells and important in maintaining homeostasis of plasma cells. A key difference in the two CAR Ts is that on the left, for ida-cel, it targets one molecule of the BCMA, whereas cilta-cel on the right has two binding domains, and we call it biepitopic. Studies of ida-cel are shown on the next few slides. In the registrational study called KarMMa-1, 128 patients had received the therapy with a median of 6 prior lines of therapy, so heavily refractory patients. 35% of them had high-risk cytogenetics, 39% had extramedullary disease, which is a poor risk factor, and more than 90% were triple-class refractory, meaning that they have failed a proteasome inhibitor such as bortezomib or carfilzomib, an immunomodulatory drug such as lenalidomide or pomalidomide, and an anti-CD38 molecule in the form of daratumumab or isatuzumab. And you will see that this is very much the population of patients that we are dealing with in these pivotal or registrational studies for both CAR Ts and bispecific antibodies. The response rates are shown on the diagram on the left, whereby clearly there was a dose response, with the 450 million cells that I've marked out for you in that circle being the most effective. At this level, the better than CR rate was 39%, with an overall response of 81%. The duration of responses are shown on the top right, and this varies according to the level of response, with medians varying from 4.5 months to 19 months. The median progression-free survival was 8.8 months, and the median overall survival was 19.4 months. On the basis of these results, ida-cel was approved in 2021 by both the FDA and EMA for patients who have received 4 or more prior lines of therapy. It's, however, very important to explain, especially for those of you who haven't come across CAR T cells before, the possible side effects. And the two main side effects of interest, which are particularly of concern in immunotherapy, is cytokine release syndrome and neurotoxicity, which I'll be referring to in both the CAR T and bispecifics. Neurotoxicity referring to brain and nerve toxicity, which is given the name immunoeffector cell-associated neurotoxicity, otherwise known as ICANS. Both of these important side effects can range from very mild to very severe and can be life-threatening. For cytokine release syndrome or CRS, in the mild setting, this can lead to only fever, but in more severe grades, it can lead to low blood pressure, low oxygen levels, needing even intensive care support. As you can see in this trial, CRS of all grades occurred in 84%, but only 5% were severe. Similarly, for neurotoxicity shown here, it can range from mild grades, for instance, patients have some confusion or have difficulty finding words, to a very severe syndrome with full-blown coma and muscle weakness, again needing life support and intensive care. For this trial, you can see neurotoxicity of all grades was 18%, with 3% severe. Hypogammaglobulinemia, which means a lack of normal antibody production, is also a common side effect, occurring here in 21%, the majority mild. Then there are the whole series of cytopenias or low blood cells, which you can see with the rate of 89% severe neutropenia, low white blood cells, 60% severe anemia, and 52% severe thrombocytopenia or low platelets. Pleasingly, a phase 3 trial is, sorry, I've just been wrong. Pleasingly, a phase 3 trial is now recently published in February for ide-cel for patients with relapsed myeloma who has received 2 to 4 prior regimens previously. They were given ide-cel at the same dose range, and this was compared with one of 5 standard regimens, which you'll see on the right. In that brown box, again, a highly refractory population with almost with 2/3 of them triple class refractory and 95% refractory to daratumumab. At a median follow-up of 18.6 months, the median progression-free survival was 13.3 months in the ide-cel group, as compared with 4.4 months in the standard regimen group. A response occurred in 71% of patients in the ide-cel group and in 42% in the standard regimen group. Both were highly statistically significant in favor of ide-cel. Adverse events were as expected with CRS and ICANS. So being a phase 3 study, comparison of 2 arms, this study is notable for showing superiority of CAR T over standard therapy in this group of patients. Turning to the other CAR T cell, which is cilta-cel, this being the one with 2 epitopes of BCMA targeted, the pivotal study or registrational study called CARTITUDE-1 enrolled patients with relapsed myeloma, again with a median of 6 prior lines of therapy, so highly refractory, having received the same 3 groups of drugs of proteasome inhibitor, immunomodulatory drug, and anti-CD38 therapy, of whom 24% had high-risk cytogenetics, 13% had extramedullary disease, and almost 90% were triple-class refractory. The results shown here are the latest update published just last year, with a median follow-up of approximately 28 months, showing an impressive overall response of almost 98%, as well as an impressive stringent complete response of 82.5%. The progression-free survival and overall survival curves are shown here, and the survivals were not reached at 27 months median follow-up, and the 27-month progression-free and overall survival were 54.9% and 70.4% respectively. While one shouldn't be comparing between trials, and this is a maxim for all trialists, as it's impossible to know that all the factors which contribute to the results are the same between trials and accounted for. But bearing in mind that the median PFS or progression-free survival and overall survival from the KarMMa-1 study that I showed you just now were 8.8 months and 19.4 months respectively, these survivals for CARTITUDE-1 of median not reached at 27 months appear very impressive. It is also important to know that there are historical studies, including one called Mammoth, which looked at survivals of a similar group of patients who were refractory to daratumumab. The overall survival of those studies was between 9 and 13 months. On the basis of these results, cilta-cel was also approved by the FDA and EMA for patients who have received 4 or more prior lines of therapy. As with ide-cel, I will now point out the adverse events of cilta-cel as reported in the pivotal trial, showing a high incidence of cytokine release syndrome of 95%, but only a small number of 5% was severe. While for the neurotoxicity, the overall incidence was approximately 22%, but 12% were severe. It is also noted that in the earlier patients, in the earlier phases of the trial, there was a late onset Parkinsonian type movement disorder. However, further experience in the use of cilta-cel has enabled us to reduce the incidence because it appears to be affected by the amount of tumor present at the time of treatment, such that if bridging chemotherapy could be used to reduce the tumor load before CAR T cells are infused, this would reduce the incidence of this late onset movement disorder. Again, as you can see on the left-hand side of the slide, there are significant cytopenias, including severe grades, similar to ide-cel, which are managed as per all hematological malignancies. There are ongoing trials with cilta-cel which come under the umbrella of CARTITUDE-2, and I show this slide simply to indicate that there are a number of cohorts of patients who are intensively reviewed, including those with biologically aggressive disease with relapse less than 12 months after the initial frontline therapy. In the interest of time, I will stick to the published data, and cohort C on this slide was just published about a month ago. And I would like to go through it also because it provides important data to inform overall strategies of giving immunotherapy of both CAR-T and bispecifics. These patients in cohort C progress from treatment not only with the 3 usual groups of drugs I've already multiply talked to you about, but also non-cellular anti-BCMA immunotherapy. And these are either antibody drug conjugates called belantamab or bispecific antibodies, which I'll talk about in a moment, many of which target the same antigen of BCMA. These results are helpful, particularly to understand whether a patient who've had other therapies which target BCMA will still respond to CAR-T targeting the same antigen. In this study, 20 patients were enrolled, of whom 13 were exposed to antibody drug conjugates, or ADC, meaning belantamab, and 7 to bispecific antibodies. 16 of them, or 80%, were refractory, so not responding to these previous anti-BCMA therapy, and 6 had received these therapies as their last line of therapy just before the CAR-T. At a median follow-up of 11.3 months, the overall response rate was 60%, and 7 out of the 20 or 35%, or rather 7 out of 10 evaluable patients for MRD, were MRD negative, so they were not, that minimal residual disease was not present in 70% of evaluable patients. The median duration of response was 11.5 months. So what this trial tells us is that patients who have failed prior anti-BCMA therapy of other types can still respond to CAR-T therapy, in this case, cilta-cel. However, this next slide perhaps bears some of the most interesting messages. The investigators in this cohort C trial analyzed what the factors were that were associated with a response in these patients. Again, considering that crucial question, when a patient relapses from non-cellular anti-BCMA therapy, is it still appropriate to use CAR-T therapy directed against the same target? In this study, the factors that are associated with response were shorter exposure to previous anti-BCMA treatment and longer time from the last BCMA treatment to cilta-cel infusion. Importantly and encouragingly, most patients in this study who responded to cilta-cel did not respond to the prior anti-BCMA therapy. Again, meaning that just because the patient did not respond to the bispecific or belantamab previously does not mean that he or she would not respond to CAR-T. So summarizing the developments of CAR-T, here's some of what has been done more recently and what's coming, with the trials performed in Australia marked by the red asterisk. Our center at Royal Prince Alfred, or RPA, and others in Australia have participated in the CARTITUDE-4 study shown on the left, which is a study to see whether CAR-T should be brought earlier in the relapse treatment regime. This was a phase 3 study looking at cilta-cel compared with standard of care in patients with 1 to 3 prior lines of therapy. This will be reported very soon, and I can assure you will be of great interest. CARTITUDE-5 is currently ongoing in our center as well as others, where we are treating newly diagnosed non-transplant eligible patients with either cilta-cel or lenalidomide maintenance following VRD induction. CARTITUDE-6, this is a trial that we hopefully will be activating soon, is the equivalent of CARTITUDE-5, but looking at transplant eligible patients, comparing cilta-cel with autologous transplant, hoping to answer the question of whether CAR-T will one day displace transplant. The trials listed on the right using ide-cel, which has not yet been in Australia to date, but are ongoing elsewhere, include those looking at high-risk newly diagnosed myeloma in conjunction with other drugs, one of this being a GSI or gamma secretase inhibitor, which is aimed at increasing efficacy because by inhibiting this enzyme called gamma secretase, which reduces the amount of BCMA on myeloma cells, it may increase the efficacy of the CAR-T. And thirdly, KarMMa-9, which is likely to be the first ide-cel trial in Australia, in which we will be performing in our center at RPA, comparing ide-cel with lenalidomide maintenance versus lenalidomide maintenance in patients with less than CR after autologous transplant. In addition, and importantly, we at RPA in Sydney and the Alfred in Melbourne are right now performing a novel CAR-T study using a new CAR-T known as PHE885. This is a phase 2 study, and we are still relatively at the beginning. I will now turn to describe a series of bispecific T-cell engagers, or BiTEs. As I previously explained, a bispecific, as I illustrated on the left, simply refers to the fact that the bispecific molecule is specific for two antigens, hence its name, which can therefore be used as an engager on the one hand and be specific for the tumor antigen, in this case myeloma, and on the other hand, for the T cell, thus bringing them together and activating the T cell to act against the myeloma cell, hence the name bispecific T cell engagers, or BiTEs. It's important to make the distinction between this from the antibody molecule that I've illustrated on the top right, which has a payload or toxin, such as belantamab, which also acts against the same target, BCMA, but killing of the cancer cells is by a different mechanism, being the toxin, and these are known as antibody drug conjugates. And again, different from an antibody molecule shown on the right-hand side in the bottom that directly acts against a myeloma cell antigen, such as CD38, and which then engages innate immune mechanisms of the patient without the bispecific linkage, such as daratumumab or isatuzumab. Since this talk is about T-cell therapies, I will concentrate on the BiTEs. There are now, in fact, an increasing number of BiTEs, and I will start with two which would appropriately be considered the most advanced in development, successively having been published in the New England Journal of Medicine last year, and the first already approved by the FDA, and then mention a few others in the interest of time that we've had experience in Australia. The first is teclistamab, shown here, targeting CD3 on the surface of T cells, and again, BCMA on the myeloma, that is the same antigen as the CAR T cells. And this is the one that has been approved by the FDA. Here is the registrational MajesTEC-1 study, which relapsed patients with at least 3 prior lines of therapy, including triple class exposure to the same 3 classes of drugs. Patients receive a weekly subcutaneous injection of teclistamab after receiving step-up doses which reduce the risk of infusion reaction. Among 165 patients, significant proportions of whom were high risk with almost 26% high-risk cytogenetics and 17% with one or more extramedullary plasmacytoma, The median number of prior lines was 5, with a large proportion being triple-class refractory and penta-refractory, and a median follow-up of 14.1 months. The overall response rate was 63%, with 39.4% having a complete response or better, and 26.7% were found to have no minimal residual disease. The median duration of response was 18.4 months, while the median progression-free survival was 11.3 months. The median overall survival was 18.4 months, though with an amount of censoring, which is a statistical effect. It was thought that the results of the overall survival may not be fully mature, but these results were nevertheless all impressive. Common adverse events included infections, which are frequent in 76% of patients, and severe ones, namely grade 3 and 4, shown on this table, of almost 45%. And this is an important thing to note in bispecifics. Cytokine release syndrome occurred in 72% of patients, but the vast majority were mild, whereas neurotoxic events occurred in approximately 15% of patients, including ICANS in 3%, together with the known cytopenias, including severe cytopenias as shown in the table. The second bispecific antibody that's been fully published only in December in New England Journal is taqueltamab. And this is firstly interesting as it's directed against a non-BCMA target, being a molecule called GPRC5D, which stands for G protein coupled receptor family C group 5 member D, a real mouthful again. And it's an orphan receptor expressed in myeloma plasma cells. The Monumental 1 study for taqueltamab is a phase 1 study which looked at taqueltamab administered intravenously or subcutaneously, either weekly or every other week. Given the effectiveness of the subcutaneous regime that is under the skin, and it being the one that proceeded to phase 2 and will proceed further with development and hopefully registration, I will concentrate on those results. This trial again involved patients who are heavily pretreated with a median of 6 prior lines of therapy, again with significant numbers of patients with high-risk cytogenetics and extramedullary plasmacytoma. Patients received taqueltamab at a 405 microgram dose level weekly, or twice the dose every second week. The median follow-ups were 11.7 months for the first group and 4.2 months for the second group, noting therefore that the median follow-up is really quite low in the dose given every 2 weeks. And these are represented in the first 2 columns on the diagram on the right, showing the responses. The overall responses were 70% and 64% in the 2 regimes. And as you can see, the very good partial response or better was 57% and 52% respectively. The median duration of response was 10.2 months and 7.8 months, and the rate of MRD or minimal residual disease negativity was very impressive at 69%, to a level of what is called 10 to the minus 5, which is the standard level in the 11 patients who were evaluable for MRD. In patients with previous exposure to B-cell maturation antigen-directed bispecific antibodies or CAR-T, noting that, as I told you before, this bispecific acts against a different antigen, there was a reasonable response, though lower, at 50%, whereas the response was also lower in patients with extramedullary plasmacytoma of 40 to 45%. Common adverse events were infections again in just under half of the patients, of which only a relatively small number were severe as compared with the other bispecifics, as you will see. The CRS, or cytokine release syndrome, occurred in 77%, but all but 1 case was mild, and there was a small incidence of neurotoxicity with no severe events. There were the usual cytopenias, but in addition, there were 2 rather peculiar effects which are likely related to where the antigen GPRC5D is found. And these are skin-related effects with eczema, pruritus or itching, exfoliation, ulceration, which occurred in approximately 70%, of whom 2% were severe, as well as dysgeusia, which stands for altered taste sensation in approximately 60% of patients. I will now turn to cevostamab, of which we are currently doing a trial at RPA. directed against a molecule called FcRH5, which stands for Fc receptor homolog 5, another mouthful. But this is another molecule which is found exclusively in B cells and at a higher level on myeloma cells. Again, this is administered whereby there's a step-up dosing of a weekly dose in the first cycle and then followed by a dose every 3 weeks. This trial is also of interest as it is of a fixed duration trial, whereby patients completed 17 cycles and then stopped therapy. In the original data of Dr. Trudell and colleagues, which I'll show you in this next slide, it was a phase 1 trial presented in 2021, noting that the drug was administered intravenously in the earlier study, earlier patients. The patients were all heavily pretreated, once again, with a median of 6 prior lines of therapy and 84% of patients who were triple-class refractory. The overall response, as you can see close to where the arrow is 57%, with a VGPR or better of 1/3 of patients. Importantly, a quarter of the patients had progressed through CAR T. In ASH last year, so just in December, a few months ago, another abstract was presented to show that cevostamab had a good duration of response, looking at 16 patients who had completed the whole treatment course of 70 cycles of approximately 1 year. 8 or half of the patients maintained a response for more than 6 months after stopping treatment, and 3 of the patients maintained the response at more than 12 months, although 3 had progressive disease. So the interesting aspect here is that it does show a fixed duration of this therapy, as opposed to indefinite therapy, can achieve continuation of response after completion of the treatment. The final bispecific I will mention is back to BCMA called alniratamab, with a phase 1 dose escalation study called MagnetisM-1. As before, patients has had a large number of prior lines of therapy with a median of 5. So this study had with 91% triple refractory patients and 31% penta-refractory patients, refractory to 5 lines. Adverse events were very similar to those mentioned before, shown in the table on the right and summarized below. Importantly, however, pointing out, like many bispecifics, there was a severe infection rate of approximately 28%, including one patient who had a fatal adenovirus infection. The overall response rate, again, was approximately 64%, with VGPR or better rate of 56%. Whereas for patients who had previously received BCMA therapies, the responses were still there, though lower, of overall response of 54%. In addition, in 13 patients who had CR, all of them were MRD negative. Following this, 3 other studies are ongoing or starting. The phase 2 study of MagnetisM-3, looking at patients who are triple-class refractory, MagnetisM-5, comparing alniratamab alone or in combination with daratumumab versus daratumumab, bortezomib, dexamethasone, and MagnetisM-7, in which we are participating, being a phase 3 study using alniratamab after autologous transplant. In MagnetisM-3, a cohort of the patients was reported in ASH just a few months ago for the subgroup who had not been exposed to BCMA therapies before. And in the interest of time, I will show this one slide summarizing the overall response, which were comparable to previous, as you can see, approximately 61%, with both median progression-free and overall survivals not reached, but emphasizing again the importance of infection, with a rate of approximately 2/3 of patients with 1/3 being severe. This report also providing data on COVID pneumonia because the trial was conducted during the pandemic, with a quarter of patients infected and 2 died of them. Here's a summary slide of some of the agents that are available currently on clinical trial, of which, as I said, one of them has already been approved, teclistamab being on the top line. In this fast-changing field, there are actually progressive changes to this table all the time. So if you search on the internet, there are various versions of this table. Overall, you can see, and I've marked out the key messages by the arrows on the top of the table. The first arrow showing that subcutaneous or under the skin dosing is more predominant and appropriately so, that response rates are in the 60 to 70% mark in the second arrow. The third arrow showing you that the total or cytokine release syndrome rate is high, but most of them are mild, and that neurotoxicity rates are overall low. And in the last column, I'm showing that in many trials, there are now data on the response rates in patients who had previously been treated by BCMA-directed agents, some of which I've already shown you, and this will be likely be of increasing significance. I decided to show this older slide, as I've told you, these slides of BSAs are continually evolving, which is a good thing, because it shows the rate of infections as a summary with at least 40 to 50% infection rate, emphasizing the important message that this is a significant issue for bispecifics, and prophylaxis or prevention by antibiotics is increasingly considered. So how does one pick from this list? Obviously, one would look at the efficacy with respect to response rate, durability, and ultimately survival, although the data for survival do take a longer time to become available. And as you could see from my presentation just now, many of them did not yet have informative survival curves, just response rates. The side effects are important, including infections and CRS. One may also choose according to the target, because many CAR-T targets are still directed to BCMA, though not exclusively. It may be possible to try to use non-BCMA targets initially if there was a possibility that a patient may benefit from CAR-T in the future. Even though from the data I showed you just now, there are responses in patients who have been exposed to CAR-T directed at the same target. Of course, cost and availability are crucial issues. Furthermore, there are already combination trials, as I alluded to, with known agents such as anti-CD38 or daratumumab and proteasome inhibitors, and their efficacy in combination may affect the choice as well. Finally, I'd like to look at what to do when a patient fails therapy, and in particular from CAR-T therapy. Despite our hopes for CAR-T, unfortunately, patients still do relapse. And this is a review performed at University of California, San Francisco on 78 patients who relapsed from CAR-T. Here are the therapies that these patients received following relapse, and there's a whole variety of them. Some went on to another CAR-T and other therapies, including bispecifics, and there was, as you can see, still a significant percentage of response in some of these patients. And here you can see the median overall survival following the relapse from CAR-T was 14.8 months, bearing in mind that this is a median level. And of interest, the median overall survival of patients who received another salvage BCMA CAR-T or bispecific within 6 months of initial relapse had a median progression-free survival of 18 months, which is an encouraging finding and higher than the other figure that I mentioned just now of 14.8 months. So why do patients relapse either from CAR-T therapies or BCMA? This slide explains some of the possible mechanisms of CAR-T resistance, which I will also apply to BCMA as required. The mechanism may be intrinsic to the CAR-T cells, whereby either the cells don't persist or they become exhausted and therefore inactive, as shown in the left-hand panel. They may also relate to the myeloma cell, in which the target, whether it be BCMA or something else, is expressed at a lower level, such that the T cell recognition and killing mechanisms therefore become less effective. And this would also apply to the bispecifics. Whereas the final mechanism shown on the right may be due to the microenvironment, which is the milieu in which the myeloma cells thrive, whereby there may be molecules or chemicals which suppress the activity of the CAR T cells or the patient's own T cells in the case of the bispecifics. There are now clear data in the literature showing that native T cells in myeloma patients are deficient in activity. And here are some of our data showing that they have low proliferation and senescence, and that these characteristics occurred in T cell clones. Our colleagues in the United States have since derived data that a patient's T cell health with those who have fewer of those senescent clones and a more diverse repertoire of T cell activity, recognizing more proteins and antigens from the cancer, is associated with longer durability of the CAR-T response and longer progression-free survival. Continued efforts are also being made to expand this repertoire of targets of T-cell-directed therapies, as shown in this recently published diagram for both CAR-Ts and BiTEs. So I've actually come to the end of my talk, and I'd like to end it with a number of questions for the future with some of my own answers. But I've put the word answers in inverted commas because this is as far as I can see them, and we certainly don't have all the answers yet. First of all, is it a matter of CAR-Ts or bispecifics or both? And if both, how do we sequence them? Well, we don't know yet. And in a practical way, given the restricted availability in our jurisdictions, the practical advice would be to use them as they become available and according to the data available so far. This will obviously depend on a few key points. As I've shown you, there are certainly data available that CAR-T and BiTEs are effective in some patients with prior T-cell therapies, even if they've been treated before. And this works in both directions. The second point being that we've seen the durability of CAR-T therapies because the follow-up of the main trials of CAR-T has been longer. What we don't know yet is whether the BSAs will match the durability of the CAR-T. And this is why I mentioned the follow-up in each of the trials. As I already mentioned, we do have combination trials occurring. Will this affect efficacy and safety? The next question is, as I just mentioned, myeloma is a disease which associated with problems with T-cell function, as data from our own laboratory have consistently shown over many years, and that studies have now shown that T-cell health matters. So should we use CAR-T earlier, or should we even consider collecting T-cells at an early stage of disease for a rainy day? And I raise this issue with a bit of trepidation because this is a very resource-heavy undertaking to collect for a rainy day. And even in autologous transplant programs for stem cells, it is in general not possible, due to the resource issue, to store cells for the future just in case. Then there is the related and very challenging question that hopefully the current trials will answer. Could earlier use of CAR-T in fact lead to a cure? And related to that, could current modes of therapies, such as autologous transplant, be eventually replaced by CAR-T? And that will be answered by one of the trials that we and others hope to commence in the near future in Australia, CARTITUDE-6. And the final and important question is whether CAR-T should be reserved for late lines or aggressive disease or used earlier. To my mind and others' minds as well, the answer is probably not. From the KarMMa-3 study data that I showed you, and given the effectiveness of cilta-cel as seen in CARTITUDE-1 for late relapse patients, we also eagerly await the answer from CARTITUDE-4 in patients who are treated with cilta-cel with 1 to 3 prior lines of therapy that is earlier in their relapse. I will stop here, and I'm happy to take any questions, but before I do that, I'd like to acknowledge all the colleagues in my unit, including the myeloma research unit, especially Dr. Christian Bryant and Edward Abadia, and our clinical trials unit colleagues, and all the patients and families who put their trust in us. I will turn back to the last slide in case it might generate some thinking points and questions. And thank you very much for listening to me.
Thank you, Joy. Such an informative session and encouraging, isn't it, to see all of these drugs in research and trials, especially when you say that slide is changing almost weekly, it would seem. Thank you for covering some of the questions already in your last slide. We do have a few that have come through from the live chat, some in line with what you've mentioned there, particularly the last question there. There's a question just about whether high-risk cytogenetics would make it more or less likely that T-cell directed therapy would work.
This is something that is not known. And as you know, with all clinical trials, it is always important to analyze the high-risk cytogenetic group to see whether that group has affects the overall response. And it would be fair to say that from the results available so far, these patients do respond. And I would answer your question simply by reflecting the data that have been published, and indeed in many trials. I would say to you that it makes more sense for the use of CAR T cells because the mechanism of killing is very much across the board. If the antigen is there, and all the surrounding conditions, including the microenvironment, as I said, the expression of the surface antigen, and the CAR T cell being present and not exhausted, it should work. Then you will say, well, why doesn't it work in some high-risk cytogenetic patients? It could be those very same factors. So my answer to you is that it makes sense to use T-cell directed therapy in those patients with high-risk cytogenetics, because it may, in a general sense, overcome some of the other mechanisms which lead to resistance with cytotoxic and other chemotherapy.
Mm, thank you. Thank you, Joy. Another question, which we do probably hear a fair bit coming through our groups, given that we look after regional areas as well. But if someone's interstate or regional, how might they get access to these trials, Joy, that do seem to be focused in our major metro hospitals?
Yeah, so be fair to say that in the initial trials that they, and particularly because RPA has been in CAR T since the initial lymphoma programs, so obviously with that experience, those centers which started doing CAR Ts, in our case, it was in 2015-16, so it's now 7 years, tend to have that experience and would be more selected, I guess, for subsequent trials. But I want to encourage our patients in all the rural regions to say that from our experience with myeloma, which has really been a second wave because lymphoma and acute lymphoblastic leukemia led the original strategies. So you will see, for instance, that CARTITUDE-4 was more widespread. Certainly CARTITUDE-5, in the case of CARTITUDE-4, there was only Sydney and Melbourne, but CARTITUDE-5 has expanded, and I suspect that CARTITUDE-6 is also very similar to CARTITUDE-5. So I'll answer the question by saying that I anticipate the studies to be kind of more widespread. I do understand that they still have to be in metropolitan hospitals because there is a significant amount of infrastructure that is required in terms of collection of the cells, processing of the cells, as well as the care of the patients with very close communication, for instance, with intensive care, neurology, respiratory physicians, and infectious diseases, given all the possible side effects I've told you about. So it still necessarily needs to be done in metropolitan regions, but I'm sure that those metropolitan regions will expand.
Mm. Thank you. Another question coming through from Veronica, who's asking about the likelihood of a therapy being approved in Australia in the near future, and asking whether cilta-cel will be put up to the MSAC again this year. Are you able to comment on that?
I can't comment on whether it will likely be approved in the future, but I'm aware that it will be it will be reassessed.
Thank you.
I think that is well known.
And another question that came through was about the manufacture. So knowing that, people are aware that it's expensive because these things are coming from overseas, is there any moves for local manufacture of CAR T therapies or the bispecifics?
Yeah, so at the moment, myeloma CAR Ts are all manufactured overseas, and this is related to the fact that the sponsors or the manufacturers who devised the original myeloma CAR Ts were located overseas. It would be fair to say that there are a number of units which have the capacity to manufacture in Australia. And I will say to you, for lymphoma, currently there is a clinical trial in Brisbane in which CAR Ts are manufactured there. So I would say to you, look, there is the hope that there will be local manufacture, but I really can't say anymore because, as you can imagine, it's not only the knowledge or the capacity, but it's also the tricky issues of funding and so forth.
Absolutely. Thank you. We are out of time. Any other questions, we will respond via email. So please do submit them via the nurses@myeloma.org.au email. Thank you so very much, Professor Ho, for your time and your expertise. It's been really wonderful to have you speak today. Thank you so very much.
Thank you very much, Gav and Diana,
Thanks.
who's also on the line. All the best. Bye.
Thank you.